everybody. Welcome to the Research Roundtable. Our guest is Dr. Melissa Aldrich, and you will see that Dr. Karen Herbst is not our moderator tonight. She is in Italy, as so many clinicians and patients are right now for the Lymphedema World Congress in Italy. We are so honored to have one of our original anchors of this research roundtable, Karen Ashforth, who is a renowned expert in lymphedema, a fibrosis expert, a pumping expert, and has collaborated with Dr. Aldrich in the past. They're going to have a great conversation. We're really glad that you're here. Carol Moody says hi from Missouri. Tell us that you're here. Show us who you are in chat. We want to hear from you, but I want to do a proper introduction of our guest. Dr. Melissa Aldrich received her BA in biochemistry from the University of Texas, Austin, her MBA from the University of Houston, and her PhD in immunology from the University of Texas MD Anderson Cancer Center at UT Health Houston Graduate School of Biomedical Sciences, focusing on severe combined immune deficiency. Dr. Aldrich's interests lie in investigating immune factors that influence lymphatic dysfunction and in translating lymphatic imaging technology to the clinic. From studying breast cancer patients with high risk to develop lymphedema, to investigating immunological changes that contribute to lymphedema, Dr. Aldrich brings a wealth of information to tonight's roundtable. And it must be mentioned that her groundbreaking study of pneumatic compression therapy for lymphedema produced visual proof that this modality enables lymph movement in stages 1, 2, and 3 lymphedema patients. You're smiling, Karen Ashforth, because you were well involved with that study as well. We're going to be talking about pumping, exercise, BMI, ALND, and so much more. And we will get to your questions. So feel free to put those in the Q&A. Use chat to just chat amongst yourselves or comment on the content tonight. But with that, I am going to disappear and say, experts, have at it. We are all ears.
Thank you. That is so sweet, Brenda. And Karen, I feel like it's a reunion to get to see you. We had such a good time working on that study. I think it's been 8 or 10 years now since we did that study. And it turned out to be a lot more important than I realized at the time, because that video evidence that we produced showing with a clear lymphopressed garment, we showed that lymph was pumping in response to the pneumatic compression therapy directly. That was proof given to some of the medical insurers that they needed to continue to reimburse for this particular technology, because at the time they said, no, we don't really have proof. We don't know if we should do that. That was the proof. So Karen was instrumental in helping that study happen and for that video to be produced and that data. So yeah, we can field questions about anything, but I thought I could talk a little bit about pumping since we already were talking about it. I can share slides, and I will try to do that here and see if I can show a few, hold on here, a few movies. Okay, here we go. So this is a movie I've shown a lot of times before, and it shows lymph pumping. It's sped up. Your lymph only pumps about 1 time a minute, depending on where we're looking, or maybe 0.8 pulses per minute. This one, I can play it again, shows it coming out of a hand area, up an arm, and into axillary lymph node basin. And this is normal. This is what you want to see. This is, like I said, it's sped up. And if that doesn't happen, you're going to have issues. You're going to have a backup of lymph, and we call this dermal backflow. You may have seen something like this before. And I was privileged enough to get to do a clinical study, an observational study that was what they call prospective, which means we started at baseline with ladies who were going through breast cancer treatment. And we looked at that pumping before they had their mastectomy and axillary lymph node dissection, or ALND. Sometimes they had lumpectomy. And then we got to see them again to see how their lymph was pumping. And then we saw them 3 more times as they went through radiation therapy. So these were all more advanced breast cancer patients. And a lot of them developed lymphedema. We wanted to see how it was developing and what was going on while it was developing. We use this technology that my boss and my colleagues, Eva Sevick and John Rasmussen, developed to basically, I call it see through the skin and see what your lymph vessels are doing, or see what your lymph is doing. So it involves microdose injections, little tiny injections of indocyanine green, which is a dye that's been used safely for decades and decades. It's been used for liver studies and all kinds of other things. And it fluoresces under the right lighting conditions. So we can see normal looking lymph like you see here, and that's contained in vessels and pumping. And we can also see abnormal lymph where it's sitting around pooled in between the cells of your body, kind of just sitting there. And this study revealed several things. Here's kind of a typical montage of what we would see as people went through the study. As they went through the study, this is before they had their axillary lymph node dissection and mastectomy or lumpectomy. And we see vessels like you just saw there going up to the axillary lymph node base. And that's what that circle area there is. And we would measure how their arm changed in size with relative volume change as a percentage of baseline. And after they had mastectomy or lumpectomy and ALND, this particular patient kind of shows a typical thing. What we're seeing, see how the vessel looks like it's getting blurrier and wider.
Dr. Aldrich, I'm going to interrupt you just for a minute. I'm so sorry, but we're not seeing your slides advance and we're not seeing animations. So,
oh, wow. Okay. So
yeah.
that's not good. Okay. So what happened is it switched screens. How about if I just don't do full screen and do this, if that's okay? Is this all right?
So we're not seeing movement. We are seeing the slide of the 5 arm
That's
images.
fine. I'm going to just go with this for now because I have 3 screens and I can't make it go to this screen to share. So anyway, what we see though, as it progresses and the lymphedema develops, we see more and more of what we call dermal backflow, which is what this cloudiness is. So what we found in this study of interest is, first of all, that the arm volume can fool you. We're always looking for arm volume to go up as you develop lymphedema, and it doesn't always do that. So lymphedema in effect can stay hidden, as you see here, where these are arms that don't have a relative volume change that's 5% or 10% bigger than baseline, yet clearly you can see that there's dermal backflow present. And so we looked at, this looks like a bunch of little doll figures on a plot. But what we did is we looked at all these subjects up here. They have numbers, and our patients, if you want to call them that. And when we had a little green figure, we saw them at a visit and we imaged their lymphatics, and everything looked pretty normal. The lymph was contained to the vessels the way it was supposed to. But when you see a yellow figure, that was a visit at which they were displaying some of that dermal backflow that I just described, the cloudiness. Lymph is not in the vessels, it's not where it's supposed to be, and it's not pumping. And then if you see half red or a completely red figure, there they were diagnosed with at least a 5% larger arm than they started with, and sometimes more. Sometimes it was 10 or 15% more. And so they were clinically diagnosed with lymphedema. And what we noticed was there were a couple of funny things. First of all, we could nearly always see dermal backflow before we saw the full-blown clinical lymphedema presentation. We also noticed that up here at the pre-ALND, the very baseline visit, 7 out of this group here, about 15% of the patients, were already showing dermal backflow before they had any lymph nodes removed. And axillary lymph node dissection if you have that, you have a higher chance of getting lymphedema. But this suggested to us that there's something else going on in addition to the removal of the lymph nodes that is driving lymphedema. So that was an interesting something we noticed. And we actually noticed that the dermal backflow could show up anywhere from 8 to 23 months before the actual arm swelling. That's when the doctor would actually call it as lymphedema, and you might then be referred to an expert like Karen, a therapist who could help you treat and control that lymphedema. So we have recently, I can't show all the data coming up next because it is under review for publication, but the questions that then came up were, okay, we know that dermal backflow shows up before the clinical lymphedema diagnosis, but we wondered if the pumping failed before that. And if so, could we catch this even earlier and get patients over to Karen sooner? So we did a study. We went back to this study actually, and we had some more subjects completed by then, and watched over 1,500 videos like the one I showed earlier of lymph pumping, and quantitated or counted how many times the lymph pumped per minute for all of those subjects, and then looked to see if that happened, if the pumpings failed before the dermal backflow showed up. And the answer is yes, it did. So there is a lot to be said for pumping. It matters a lot. So in my mind, I thought, well, maybe this means that pneumatic compression therapy could potentially have a place earlier in the progression of lymphedema. It might, that treatment might be of use earlier on when there's even a suspicion of lymphedema. I don't know that medical insurers would agree with me, but it looks to me like pumping failure is occurring first, and it might be linked to some other things that we noted. We had another, we used that same group of or cohort of subjects to look at something called cytokines and chemokines. These are things that basically float around in your body, and they're molecules that work as signal, as kind of messengers, and they tell your immune system to do this or do that. And sometimes they're doing good things like helping you clear an infection, and sometimes they're doing bad things like causing bad inflammation. So what we found, and you see all these dots on this picture here, but what we found is for a lot of the cytokines, and they have these funny names that have letters and numbers up here, but what we found is that in patients who were going to develop lymphedema a year later, we could see that a lot of these were already too high. They were compared to the people who didn't get lymphedema. And this is a year before they showed up with clinical lymphedema. So that indicates that early on, there are some immune things or some inflammation-driven things that are happening that we can't see and we don't really understand fully, but they're telling us lymphedema is coming. And if you look at some of these cytokines here, we just threw 3 of them up here. Even, they not only predict lymphedema or tell you beforehand, but they're there after you have lymphedema. These dots here are represent people who have lymphedema, and compared to people who don't have lymphedema, they have higher levels of these molecules that are driving inflammation and whatever. And here, I don't know if these movies will play. Let's see if I may have to do slideshow and it'll throw it into the wrong frame, so I may not be able to do this one. Anyway, I had mice experiments I did a long time ago, and I did this experiment because there was a subject who came into a study, and this subject was supposed to be a control, and he came in to be a good citizen. And now I can't even get this slideshow up. I'm really struggling. I'm sorry. I have too many screens here. Let's move this. Anyway, so he came in and we imaged him because he was supposed to be able to show us how it was supposed to look. There we go. Let's pull it back up here. And he had an infection on one toe. Other than that, he didn't have lymphedema or anything that would disqualify him from being a control. And as we were imaging him, I noticed that his lymph wasn't moving in his foot. And so I thought, well, I guess it has something to do with the small infection on his foot. And after the physician who was present scolded him for not taking care of this sooner, and she wrote him an antibiotic prescription, I went back and thought, maybe we can try looking at this in mice. So I had mice that were just mice, and I imaged them, and I could see here their lymph flowing up from where I injected a little bit of dye up to their axillary nodes, and it would be pulsing like this. I really do want this to play, but I may not be able to do it. Let's try it this way. No, it completely disappeared. Sorry, there's something about this screen that just won't show. At any rate, what I found was that I could inject some of those inflammatory cytokines into the mice, and their lymph would stop pumping. It just would stop. So if you can imagine in patients, if they have elevated levels of the cytokines in their plasma or their blood or all through their body, their lymph isn't going to pump. And that can contribute, of course, to lymphedema developing, because if your lymph's not moving around, you're in trouble. So let's see here. I'm going to stop sharing and then I can maybe figure it out. So to kind of continue that thought about inflammation, the next thought that we had was that if you have cytokines all over your body that are driving lymphedema, is lymphedema really just a localized disease? Is it just in your arm if you see it in your arm? And I believe the answer is no, because I looked back at some old data that we had, and they were images of women who had already had breast cancer related lymphedema. And so we would image their sides, like we'd look up here and here on the sides that were obviously affected, but we also imaged the experiment that we did was this one. Let's try sharing the screen again, and I'll show it here. So what I did is I looked at people's unaffected sides, and I found that they had abnormalities developing on the unaffected side that you normally wouldn't see, and they weren't swollen on that side, but it made me wonder, should we maybe be treating both sides? I don't know. And I think since then, a group in Denmark has come out with a paper that I saw. And in that paper, they took a little bit of tissue from an unaffected site in someone who had lymphedema. And that tissue is supposed to be normal and healthy. And when they looked at that tissue under the microscope, it had some of the same markings that lymphedema tissue has. So I think that the evidence is there that lymphedema is a systemic disease, and it's an inflammatory based disease. And so anything you do to decrease that inflammation through diet and exercise has to be beneficial. So I can maybe jump to the next thing we wanted to talk about, which is exercise. And everybody knows that I think everybody knows that there are two kinds of pumps for your lymph. One's called intrinsic, and that means little molecules, maybe like some of those inflammatory molecules that can affect how your smooth muscle cells that are around your big lymph vessels contract and relax, contract and relax, contract and relax to push lymph around. So that's the intrinsic stuff. So the molecules floating around, your inflammation will affect whether or not you're pumping. And also, if you exercise, those big muscles that surround your lymph vessels or they're next to them, when they're contracting and relaxing and moving, they're pushing on the lymph vessels and they're helping lymph to pump as well. So I remember, say 10 or 15 years ago, when I would go to conferences, I think I would see a few people presenting, questioning, we don't know if exercise is good or bad for lymphedema. And as years went by, I noticed that it's become more of a consensus that exercise doesn't hurt lymphedema, and in fact, it may be very good. So I'm kind of excited to see that progression. I don't know that we understand all the molecular reasons that exercise might be beneficial, but nonetheless, we see that. So I have another movie too. I don't know if this one will play. This one won't play. Okay, the next thing is BMI. So this is a hot topic right now. So I can't show the slides for this, but as we looked at pumping in subjects who had developed lymphedema, something that we've noticed is that if you have a lower BMI, like a normal BMI, you will pump better than someone who has a higher BMI. So there's clearly a link there. And we're seeing also that if you get surgeries, this is totally unpublished and we're putting the manuscript together right now. If you are getting reparative surgery for your lymphedema, that would be like the lymphovenous anastomoses or lymphovenous bypass or vascular lymph node transplants. If you're getting those and your BMI is lower, you will have a better outcome than someone who has a higher BMI. So we kind of see a common theme here where, exercise and diet, inflammation, and a better outcome from a reparative surgery all seem to be linked together. And that's really about all I wanted to talk about. And I apologize again for the slide failure, but I am very excited to get to work in this field. And I'm very excited that I get to do the type of work that I do, which is not just with mice all the time. I get to meet patients, and it's very, very inspirational. I wish every PhD who is working in the field would have some sort of a rotation with a physician and therapist, or some sort of an internship there to meet them, because first of all, you get to hear the stories of the patients, and a lot of times you will get clues and ideas from their stories and their odysseys. You learn, oh, this is how this worked. And you can't get that from just reading papers about mice and experiments in mice. And also, mice are not humans, of course, we know that, but they're quadrupeds, so they don't really develop a lymphedema like we do. We stand up and we have to fight gravity more to move lymph around our body. So it's the experiences with mice are never going to be the same as those with humans. So I'm very grateful to this study subject. I don't know if Karen would like to speak for a while. I've been talking and talking and talking, which I love to do, but I'm happy to take questions or talk discussion points, or hear what Karen's up to these days.
Dr. Aldrich, this is wonderful. And we really appreciate you sharing this information. And even without animations, your slides are very interesting. And I think that if you want to go ahead and stop sharing so that we can see you full view, that would be great. And I actually have some questions that have come up as a result of what you've just now shared, which is wonderful and fascinating. And I love that your research with ICG is showing how early lymphedema occurs before it's, even detectable by circumferential measurements. I'm curious, are you incorporating bioimpedance at all into your studies? Because that's another early detection.
Yes, and we don't do it. We work with people who do it. And I've seen the papers, I've reviewed some of the papers. I think it is part of the toolbox that you can use. We did just do a little bit of a regression analysis looking at what we use, which is the near infrared fluorescence imaging and bioimpedance that were done on the same patients. And we didn't see bioimpedance pick up the BMI difference like we did with our imaging. And they're just different technologies.
Yes.
We're just trying to see the fluid. We want to see where it is or detect it. And it's, of course, probably more expensive. I don't know that it's necessarily more expensive, but indocyanine and green lymphography is not as widely available as bioimpedance. In fact, it's really not available. That may change. I think they finally have some ICD codes for it. And I think as the value of that imaging is shown, it'll get incorporated more frequently. But bioimpedance is easier to move in to the clinic. It's there.
Yeah. Well, it's not currently accessible to many clinics, but what I'm hearing you say is that it's certainly a lot. The imaging that you're doing is so much more sensitive to picking up uh, signs of inflammation earlier
Yeah.
than even bioimpedance, which
Mm.
is wonderful and amazing. Um, we do have a question, let's see, from Eileen asking, uh, should I be using compression longer in the earlier stages after axillary node dissection, with or without radiation therapy? She's using bioimpedance and TDC for detection. So she'd love to hear your thoughts on the length of compression.
So I make a disclaimer right up front. I'm a PhD. I'm not an MD, or I'm not a Karen Ashforth who is really more qualified to answer. But um, there is probably a cutoff. I do remember seeing a paper where they compared using pneumatic compression once a day versus twice a day. And if I remember correctly, once a day was good enough, that there wasn't a big difference between the two groups that they were comparing as far as what was happening. They didn't use indocyanine and green lymphography for that. They used some other methods, but nonetheless, it sounded to me like something's better than nothing. And the something that they were doing was adequate. And I believe, the pneumatic compression companies have a good idea of what is, in the therapist, of course, what is an adequate amount of treatment time, because I really don't know, but
Yeah, just in terms of compression, even static compression, elastic sleeves, there's been a lot of data, especially Nicole Gergich-Stout has done a lot around being able to use compression early on as a way of helping lymphedema. So we've got a few other questions. Um, and I know that you're more of the expert in the Nerfly imaging, but Kathy Plavcan, sorry, Kathy, is asking about ultrasound imaging, looking promising for lymphatic imaging, and why is this not more widely available? And I'm just going to jump in because I don't know if you have an opinion, but I'll give mine first, which is that um, real good high frequency ultrasound imaging is extremely expensive. And I use a cruder form of imaging, which looks more at tissues, but not at the lymphatics specifically. It can pick up fibrosis, it can pick up dermal thickness, it can help me distinguish lymphedema from lipedema, and give lots of information. But to actually use ultrasound to image lymphatic pumping, that takes an instrument that's incredibly specific and very, very expensive. Would you agree with that, Dr. Aldrich?
absolutely. But ultrasound has place, and it's a really important tool. And I'll give an anecdote to describe it. So we had a subject come into the study that we did together, Karen, and they weren't sure if she had lymphedema because her lymphoscintigraphy results were normal. Yet there were swollen ankles and complaints of the pain and the usual. So, and before we saw her and did the indocyanine and green lymphography, she visited, I think, the Foldy Clinic. And there, they weren't sure either, but they did ultrasound and they said, the skin's starting to thicken and we really think that it's probably lymphedema. So then she came back here, we saw her, and sure enough, there it was. So there's a confirmation that ultrasound's detection of thickened skin correlates to what we see with indocyanine and green. So it's a very useful tool, but yeah, I don't know about it. Seeing lymphatic pumping with that is going to be not going to happen. But anyway, yeah.
Yeah, thank you so much for that. And the questions are flooding in now, which is really great.
Okay.
So there's some questions about body mass, and uh, Marty Klein asks, does BMI and outcome relationship hold for people with non-lifestyle adipose tissue causing higher BMI, such as lymphedema?
No one knows that. That's a really good question because, there's just there's so many questions swirling. I feel like this is a tsunami that's going to come hit us, lymphedema,
Yeah.
as people realize what it is and become aware, and we start to parse out how to best detect it and discriminate between lymphedema, and normal obesity. We don't know. So there's not a good answer for that question. If it's lymphedema, it's funny with lymphedema, it seems like they are protected from getting diabetes, which tells me that the immune things that we see with lymphedema aren't necessarily there with lymphedema. So I don't know. I don't know.
I would agree with you that there's still so many unanswered questions about lipedema, and um, we we know that there can be inflammatory processes there. Um, Another question is, can lipedema lead or cause lymphedema? And I'm just going to jump in on that one because there have been some studies. Shelley Krasinski has been taking a look at MRI
Yeah.
and lipedema, and has identified swelling in every stage of lipedema. And so our old way of staging lipedema, where stage 4 was formerly called lympholipedema, is a misnomer, because we can have lymphedema in any stage, but whether lipedema can lead to or cause, we still don't know the answer to that. We're still looking at the relationship between the two and acknowledging that the two do coexist quite frequently and need to be treated, each of them, both of them. And often the treatment can be similar, but definitely swelling can be a big component of lipedema. I want to back up for a second because we have both patients and clinicians at this talk. And can you just define, just give the Wikipedia definition of the ICG imaging that you do? And because early on, I heard you talk about pumping, and for just a quick second, I thought about pneumatic compression pump, and then realized that you're studying the actual lymph pumping. But just talk a little bit about the imaging that you do and what it is and what it looks like.
Sure. Hang on just a second. I actually may want to share a slide again because I have some. So what we do is we have, here we go, share slide, and it won't do anything funny. Here we go. Sorry. It's this one here. And share. There we go. So I don't know if you can see this now. Here's someone's lying in a bed, and there are these cameras hanging over the arms here. And a little bit of dye has been injected in each hand. And as you know, lymph is supposed to move this way. So we put the dye distal, we put it down here. And for legs, we put it on the feet. And watch as it comes through. So what happens is, indocyanine green is this magic molecule that is green, and it's been used because it's so bright and green. You can just see it in liver, or I think in backs of eyeballs, they'll use it for that. But it also fluoresces, and it fluoresces in a certain part of the rainbow, the light spectrum. That's the near infrared part. And I'll hold this up and see if you can see my flashlight, but you can see the red glow through my hand. I'm using my phone flashlight. That red glow you see is not due to my blood. It's due to the fact that that particular wavelength of light is not blocked by hemoglobin or melanin or water or other things that make up tissue. So there's kind of a sweet spot in the light spectrum, the rainbow, if you want to just use that. And you can see through skin at that wavelength. Well, that happens to be the same wavelength that indocyanine green. If it gets excited by a little bit of laser light, it will fluoresce at that wavelength. So we can see it through the skin, and we can see your lymph through the skin. We can see your lymph in the vessels through the skin. And we can see, here's a slide that may show the thing. We inject a little bit down by the toes or by the fingers to do this, and you'll see it go in and go up, up the foot. Here we go. There it goes. So that's how we use it. And
So we're actually seeing the lymph flow, and but it looks green because of
we just make it look green. It's actually
yeah.
the way the camera's captured it, it's gray, but that's too boring. So we put this in. But that's true. So we can do that. And there are commercial varieties of this imaging that are used by surgeons that do the microsurgeries, the reparative microsurgeries, and I'll talk in a second about a preventive surgery. And ours is a little bit different in that we have a different setup inside the camera. So this is like kind of a comparison of the commercially available, which is fine. It's a good system, but we can we have a better signal to noise ratio and a better contrast, so we can see the lymph pumping because we can capture frames really like 200 microseconds apart and put together movies and see it pumping, whereas the commercially available systems will be able to see your vessels just fine, and the surgeons use that to find the vessels that they want to use for the surgeries. But ours, we can see the pumping, so there's a little bit of a difference because of that. But otherwise, it's just been a really useful tool. And where was I going with this? Let's see. The question was about indocyanine and green, seeing the pumping, and then there was another part to the question, wasn't there? Or
I think just understanding that, and could you please clarify, Dr. Aldrich, when you are imaging, how deep can you image?
So we know it's 3 to 4 centimeters. The commercially available systems will tell you maybe a centimeter. We know ours is 3 to 4 centimeters because we saw some lymph nodes in a subject that were about to be dissected out. And so when the surgeon took them out, they confirmed they were between about 3.5 centimeters down, and they were the same lymph nodes we had seen. Now, if there's dermal backflow, the cloudiness that's sometimes more surfacial, like on the surface of the skin, sometimes that can make it a little bit harder to see the deep vessels, but not always. Sometimes we'll see deep vessels underneath, they're pumping away. So you'll have dermal backflow kind of on the surface, and then underneath there's a vessel that's still pumping down below. And it looks a little bit blurrier because it's deeper and there's more light scatter the deeper you go. But that's 3 to 4 centimeters we can see. So
That's great. And, I'm just wondering if the scenario that you just described, if that dermal backflow might be disruption of the surface lymphatics and, maybe by some fibrosis, either scar tissue or maybe the patient's developed lymphostatic fibrosis, and it's the deep channels that are doing the majority of the work in terms of pumping the lymph. Does that sound right?
it does sound right. And I think there might be patients in whom the deep stuff's working and the surface is not so great, and maybe things aren't so bad. Or some patients in with both systems are not working very well. So we really don't know. We don't know. But yeah, it's pretty cool. I want to mention too, there is a new type of surgery. Well, it's not new, it's been around, but there's something called immediate lymphatic repair. And this is what is almost becoming standard of care at a lot of cancer centers. And so what happens is you have, say, breast cancer, you're going in to get axillary lymph node dissection because they've determined that you have cancer in those lymph nodes, they need to come out. But they know that you're going to be higher risk of lymphedema, partly because you're taking out the nodes and partly because your cancer is worse. Again, remember, sometimes you see lymphedema before you even get the lymph nodes taken out. So it's a chicken and egg question in my brain. So what the surgeons will do is they'll wait until the axillary lymph node dissection is complete, and then right away they'll go in, same surgical session, they'll go in and connect some of the severed lymph vessels to an axillary vein so that they basically laid a pipeline to make sure that lymph has a place to go. They didn't just pull out lymph nodes, cut stuff, and leave it just like hoses cut off that don't have a place to go. And so they lay that pipeline. And some studies have shown that this prevents lymphedema, and some studies show that it doesn't really make a difference. So we don't really understand what's going on there. But I had one subject who came through an early study, and she had this surgery done. And I got to image her with indocyanine and green lymphography before and after, and along the way, I like 6, 12, 8 months, 2 months later. And what I noticed is that she still developed lymphedema, and she had the pipeline laid. It was beautiful, the surgery, I mean, beautiful surgery, but she wasn't pumping, and she still got the lymphedema. So if you can think of a river that's flowing quickly, it'll move water out to sea very well. If it's a river that's stagnant and just sitting there, things get smelly and you don't move water out to the sea. So I think that the pumping matters story is very big there. And I wonder if there is any move to initiate pneumatic compression therapy at earlier stages for those patients who are getting that particular preventive surgery to increase the odds that the lymphedema will be prevented. So I don't know the answer to the question. All I know is what I saw. So
No, that's very interesting. And I'm just wondering with this case that you saw, I'm curious whether her levels of cytokines were tested.
they
And
were, they
were
were,
they?
some of them were, yeah, some of them were higher. I wish we had done a better job of, we found some certain ones that we expected to be higher, and they were, but we didn't do a meta-analysis to figure out, well, exactly which ones and what are they doing. And that's because it's very difficult with cytokines. We looked at 30 some odd cytokines. There's a lot of them. And sometimes some of them, we call them pleiotropic. Sometimes they do one thing, and then in another situation or in combination with another cytokine, they'll do the complete opposite. So they might be a good guy or they might be a bad guy in certain situations. So it's kind of hard to dig through that. But I think as AI is developed, someone will be able to sort through that. In fact, someone already did, some researchers from Canada took a look at our data and combined it with theirs to try to pluck out some maybe more biomarker type information. But we're not there yet. So.
Yeah, no, I mean, there's so much on the horizon. That's amazing. Wow. Well, I mean, kudos to you. I mean, your work has just really progressed since we worked together, and it's so exciting to see what you're up to right now. Do you have any other studies on the horizon that
Oh
you're
yeah,
thinking about?
a lot. I can't really talk about them. I want to, but they're immune based and
Uh-huh.
just build on the inflammation story and then the pumping story that and indirectly. So I'm real excited about those. You know, immunology was what I was trained in initially, and I just that disease I studied when I was in grad school decades ago, they now have it. It's cured now. They have gene therapy now, where
Wow.
they did. I read in the newspaper the other day and I started crying. So it's
Oh,
just a good lesson for everyone that as painfully slow as research seems, and it has to be slow because it's very complicated. At some point, there will be a cure for lymphedema. There will be an answer to this. It's just a question of when, and it's gonna happen. So you know, that's why I'm in it. I love it. I love being a scientist.
that is a wonderful message of hope. And I think even the dots that you've been connecting recently about BMI, cytokines, inflammation, and seeing lymphedema before it even presents itself physically. I mean, this is huge. And it's, one more piece of the puzzle. We
Yeah.
keep getting closer and closer.
And there's more to the BMI story. I'm not sure it's the whole picture, but this is other people's work. But Joseph Diane, as you know, is recruiting for a study of what they call GLP-1 agonists. So these are molecules that are big, that they're Ozempic is a brand name. I'm not supposed to plug any particular thing, but there are a lot of drugs that are in this class, and they've shown remarkable efficacy in weight loss and diabetes prevention, and I don't know if it's diabetes cure at this point, but um, there is a study that he is doing, Joseph Diane's doing, to see if these can help with lymphedema and improve the symptoms. And he made a presentation at a conference I just recently attended that says that the answer is it's very possible. So there's a lot of hope and but still a lot of unknowns. And VMI is probably part of the picture. So yeah.
Well, and inflammation. And I know that in the lymphedema community, we're seeing a lot of people responding to the use of GLP-1 agonists and how it's not just causing weight loss, but it's causing inflammation changes. And I've been reading about the use of them in mast cell and how that's having amazing effects for many people. So there are all these applications that you never would have thought of when, the drugs first came out. Um, and yeah,
That's always how it works.
yeah, yeah. So there's a few more questions, but they're not necessarily oriented towards your topic. Kathy Plavkan has another comment about not as expensive as NMR, known as MRI medically, that is promising and requires a huge magnet. Liquid nitrogen looks at water and soft tissue, proton flipping imaging. So I think that was just kind of a comment in terms of how there are so many different ways of imaging at this point. But your ICG is becoming almost mainstream at this point because so many more facilities are doing this and really using it to target problems with lymphatic stasis and pumping.
Yeah, I have to say it's thrilling too. Every time we have a new subject come in, or even the same subject come back in a study, we're doing a study now of that immediate lymphatic repair that I mentioned before. And every time we see a new patient, it's just a thrill to see the dye go in and lets us see what we see. And you see, are the vessels going to look like this or going to look like that? It's just an incredible technology. And yeah, MRI, it can give actually higher resolution images, but it's more expensive, and you of course have to have the facility, which is like a dedicated, the whole bit for MRI. And it if you want to use contrast, you can for MRI. You don't have to, but the contrast for MRI is kind of gooey and sticky, and it's not as great at getting into the little bitty vessels like indocyanine green can do. So you don't always see exactly the same thing, but for deep lymphatics, it's been invaluable for detecting problems with with chylothorax, if you're trying to figure out what's going on with cisternus chyli, if there are issues deep, the thoracic duct type issues. And I think Max Icken is probably the expert in that field. So there are other imaging modalities that can be used. Even CT scans up, it's kind of like an X-ray on steroids, where it's tomography built images. You can see the fibrosis, the fat buildup under the skin with that. You can't see pumping, but there are other ways to image and get a picture of what's going on with lymphedema. It all boils down to what's going to be used the most is what's going to be the least expensive and the most accessible in the clinic. So I think that's bioimpedance's forte. And then as time goes on, if things shift and something becomes less expensive or more accessible, then people might shift to using that type of imaging. But right now, I'd like to say there's a toolbox of imaging technologies that are used.
That's great. Do you see anything on the horizon, just in terms of the technology itself, in terms of making it more accessible?
Yeah, I think so. I think that demand will drive accessibility. As we show the usefulness of, say, what I do or what MRI, like Rochelle does the MRI, then we'll figure out what applications, in what applications it's useful and cost effective. And then if reimbursement follows from medical insurers, then it'll be used. So yeah.
Mhm. Yeah. Yeah.
Yeah.
So we've got actually I wanted to just share Kathy Plavkan made another comment in Q&A which I think is really relevant to the group just as a follow-up on the GLP-1s about the 2025 Brazilian opinion article on tirzepatide. And she mentions it in that article as a possible missing link for lipedema metabolism. And, very exciting, complicated diagram of all sorts of cytokine fibrosis salt effects. I know Dr. Karen Herbst has been using microdosing of tirzepatide a lot with her patients and has a lot to say about that. So just wanted to share that since we talked about that with the group.
Tie back in the exercise, though, I did read where the GLP-1 agonist will cause loss of lean tissue, that muscle, more so than fat even. So it might be really important for exercise to be a part of the GLP-1 agonist picture as time goes on. I don't know how much press that has gotten, but it is real from what I can tell. And so it might be of use to be sure you incorporate exercise when you're on those
Absolutely.
medications.
Yeah.
Very important point. And there are many people in the audience that are using the GLP-1 agonists, understanding that protein intake and exercise is super important. We are at the 5-minute mark, which is usually when I pop back up here and we do any final questions and housekeeping. What a fascinating conversation. I just want to say thank you for being a champion of the kind of research that can help connect the dots to important insurance coverage. Because when people can see the efficacy of a product like a therapy, like pneumatic compression therapy, and it's undeniable that it works, then showing those images and the proof of your work can really help people make a case for insurance coverage, which is often the missing piece. We heard in the chat, people were saying, thank you for giving us hope. We want and need hope, and we love the advancing medicines, surgeries, technologies, therapies, but we got to connect the dots to the insurance coverage as well. And your work has certainly helped to do that. Do you have any final thoughts, Karen Ashforth? It was so wonderful to welcome you back to the Research Roundtable.
Oh, this is great. Thank you so much, Brenda and Dr. Aldrich. It's always lovely to see you and talk with you. And I just I want to acknowledge that there are a few unanswered questions out there that are more clinical as opposed to on the topic of imaging. And I'm going to encourage those of you who have questions of that nature. We have a lymphedema roundtable that will be happening next Tuesday. And then there's also a lipedema roundtable that Brenda anchors. And so we're not going to get to all the questions tonight, but that those might be really good forums to pose some of those questions. So I'm just going to say sorry that we're running out of time. It's so great to have such great activity here. And Dr. Aldrich, I'm just in awe of, you keep plugging on and keep pulling more magic research out of your lab. It's so great.
Well, I told Brenda when she told me you'd be on this, I said, I'm just such a huge Karen Ashforth fan. And it's so true. And so I'm just delighted I got to spend some time with the both of you today, or tonight, I should say. And hope to see you again soon.
Oh, yes, we would love to have you back. It is always an honor to share our platform with someone like yourself and Karen Ashforth. Thank you both for what you brought to the roundtable. And thank you, everybody who logged on for the live. We know a lot of people watch the replay, but we truly appreciate you. We love your questions. We love your engagement. And yes, if you're interested in our other roundtables, lymphedema, second Tuesday of every month, lipedema, third Wednesday of every month, just go to lymphapress.com. And I gotta say, if you're not using a lymphapress to manage your lymphedema, what are you waiting for? We would love to help you out. Go to lymphapress.com. We would be glad to connect you with an expert who can help you get pneumatic compression therapy that can move that lymph and give you the pumping action that your body needs to help eliminate. So thank you so much. Thank you both. And I hope everybody has a great night. We'll see you again next month at the Research Roundtable. Bye-bye, everybody.
Bye.